Hello and welcome to your health and wellness platform, Medical Mondays with Dr. O. Tonight, we'll be delving deep into the topic, depression, suicide, and racial disparity with Dr. Nelson Aluya. The purpose of this platform is not to establish care, but to arm you with all the relevant information you need to make healthy choices. We also bring you the expertise of the professionals in the field. Medical Mondays is on YouTube, so please subscribe to the channel, hit the notification bell, and then like. You can also go back and watch all previous episodes of Medical Mondays with Dr. O on the YouTube channel. Dr. Toyin Opesami is a family practitioner, HIV specialist who also treats addiction. She is CEO and medical director of a Gennesaret Medical Center, co-founder of Global Vision Foundation, a nonprofit 50c3 organization, and medical director of Global Vision Community Health Center. And she has passion for Medical Mondays. Welcome, Dr. O.
Thank you, Honorable Gustav. So much appreciate you. God bless you. Tonight, we have another amazing evening with our very own Dr. Nelson Aluya, who is trained both in pediatrics and internal medicine. He is a medical doctor with extensive broad-based training, clinical expertise in over 3 continents. He is currently an attending physician at Newark Beth Israel Medical Center and an assistant professor of medicine at the New Jersey Medical School, Rutgers University, Newark, New Jersey. He has led multiple local and international medical missions, providing his expertise and selfless service to low socio-economic groups, especially economically and socially displaced and migrant families. Dr. Aluya has been a guest speaker at numerous local and international academic workshops, conferences, and seminars, including Medical Mondays. He is the recipient of numerous local and international humanitarian and peer review awards, including the Global Humanitarian Award, nominations for the Golden Apple Award, Excellence in Teaching also. He is a recipient of the Ambassador for Peace Award by the Universal Peace Federation. Dr. Aluya is the national president of the Nigerian American Public Affairs Committee, USA, and I have to say something about that. I am chair, he's my president. I'm chair of NAPAC in 5 regions: Virginia, DC, Maryland, Delaware, and Pennsylvania. And he is our overall president. Immediate past president of the New Jersey Medical Association, that's NJMA, the chairman of the Association of Nigerian Physicians in the Americas, that I'm also a member of, and the vice president of Impact Life International, a non-governmental organization with global outreach. Pardon me. Thank you. He received a citation from the Brooklyn Borough President Eric Adams, recognition by the Mayor's Office of the City of Orange, New Jersey, and the New Jersey State Assembly citation by the Assemblywoman Brittany Timberlake, and is also member advisory board to His Excellency Ambassador Sadiq Y, Sierra Leonean ambassador to the United States of America. Dr. Aluya, you can see, wears many hats. He continues to dedicate his utmost effort to teaching, research, and to improving healthcare delivery, especially in the area of diabetes, for all of humanity, and especially those individuals of African descent, by building the framework to recognizing the barriers to care, creating social and political awareness to the debilitating emotional, economic, social burden of the disease, and more recently, the public awareness, treatment, and management of COVID-19 infection and vaccines awareness. He refers to himself as a medical advocate. Dr. Aluya is a prized jewel of ours who you can see has so much broad experience, lends himself to bettering our communities and always there when we call him. So tonight we beckoned again, and here comes Dr. Nelson Aluya. Welcome, Pressy.
Yeah, thank you. Thank you so much for that great introduction. I mean, Medical Mondays and everybody there have now become family. I think by all records, I begin to have the highest number of appearances on Medical Mondays already. But it's something that is dear to me, and I love doing this to the point that where we need to touch our families. I mean, when I mean families, those who are watching and those who are back home, because very rarely do we get people of our ancestry who are really willing to come up to give medical facts as it may be often enough, because that's the only way we can touch our families, we can educate our families, we can enlighten and elevate morally and spiritually and otherwise our families, except we come to them. And the beauty of it is maybe COVID, COVID created the scenario upon which the technology has become so possible for us to do this, where each and every one of you will be in your living rooms, wherever you are, and we can talk, we can hear each other and discuss and share ideas and everything else. And thank God, for that. I often say this: out of every bad thing comes good outcomes, and sometimes out of good things come bad outcomes. So it's just how you view it and how you utilize it to a point where you begin to take advantage of your situation, no matter how it is. Um, so it's a pleasure once again to be here, and to everybody who's back home, wherever you are across the country, across the globe. Good evening from New Jersey. Um, and it's a pleasure to be here to talk about one of the biggest issues that bothers us. Like you said, the topic, I had actually just given a talk about this. I think it was last week or 2 weeks ago, to the NAACP. And when you called me and said, "Oh, I want you to give a talk," I'm like, "Oh, okay." And I told you, I said, "Yes, this is, my spirit said we should talk about this because it's important." A whole lot of things are happening around the world. We live in a very precarious world right now with so much uncertainty, to a point where people are really confused, disheartened, disturbed about the social, geopolitical, and even military things that are happening across the globe. One, we're just getting out of COVID, and then we have Ukraine. So it seems as if COVID died a natural death, but it's still there. So it's left for us to continue to take heed. But then, with all the conundrum of what's happening around the world, it's affecting us in our psyche. And the WHO had actually described or defined health, not just, the physical well-being and securing your physical well-being, not to paraphrase, but also your emotional, psychological health as well. And for them to put that into that description and definition for health, it therefore means your mental health is really important as well. People tend to forget that a lot of things that begins to manifest in our body actually begin somewhat in our head as well. And we begin to understand a whole lot more things than we previously did. To a point where we now realize that, look, um, whatever is happening in the mind can begin to manifest in the physical, and to the point where the physical manifestation can actually give you signs and symptoms. And in the psychiatric world or mental health, what they call that, somatization, where you somatize signs and symptoms you begin to get. And when it actually gives you physical signs, where one part of your body or weakness or one of the other stuff begin to happen, it's called conversion. So these things are real, and even healing begins from the mind as well. And that's why on the spiritual aspect of it comes in, where we see spiritual healing taking place. So tonight we're just going to be, I'll use it, well, family. It's going to be a round table discussion. We're going to talk a few things, and I'm sure people will have questions. A short, what do you call it, description of how things are, and signs and symptoms from depression to suicide. I like to give statistics, global statistics, US statistics, and even statistics that bother us as a people, and of course, the great continent of Africa where we come from, and then into the nitty-gritty of what it is, why we are who we are, in terms of why we behave the way we behave, why I've said this, we're often late to anything, or we don't prepare for anything. Some of all those, conundrums that take place, because all of our pains and suffering and joy and happiness is part of our history that goes on to define who we are, and we cannot separate that from one another. It is who we are, and it's who has defined us as a people, and has defined often how we behave. And I always say this: if you don't know your history, you're like a branch that does not know it's part of a tree. And what happens to that branch? It only grows but wither and wither away. So since we do not want to wither away, we'll have to understand, know our history, understand our history, accept our history, and then use it as a platform upon which we will launch ourselves into the El Dorado, the great good world that we anticipate and willing for us as a people of African descent. Because there's no doubt, we are truly unique. We are. We'll begin to understand that now. And for those who are in the medical field, only about 3 or 4 years ago, they begin to separate the Black man's kidney function from other races. If you look at your kidney result now, when next you get your kidney result, look at it. You see non-African American GFR is this, African American GFR is this. And often our numbers are usually higher. And there's a reason for that. The politics, the gametes or whatever, that's a different story for another day. But, coming to the issue of depression, look, it affects everybody. Every race, every tribe, every creed, and almost every age, as a matter of fact. Not much studies been done in toddlers, but children do get depressed. Teenagers get depressed, adults get depressed, and the elderly get depressed. And there are risk factors for all of this, that make people and depressed. There are also chemical changes that take place in our minds that alter the way we conceive and evaluate things, to the point that they slowly begin to hinge to a point where it affects our daily mindset and how we relate with one another and the environment upon which we live in. Now, what does that mean? Mental health is a big issue. It's a big issue, and it's beginning to be a bigger issue in our environment, especially within the last 2 years. But I'll tell you this: the brain and the space of mental health A lot of us still do not know that much. I often say it's like space. We know what's happening in space. We know the planets now, where the stars are aligned, all the different galaxies, and we're giving them names. But a whole lot of things we still do not know. And that's how the human mind is, and the brain, and how we work. So we'll begin over time, begin to learn some of all this. And of course, as time goes on, with technology coming up, with artificial intelligence coming up, with blockchain and all that, enforcing some of these things, we will learn a whole lot more. And putting together in religion and all of these things together. These are some of the things that would define what our future would look like, how we relate to one another, how we would um, alter our environment to suit us, even how we will serve the God that we serve. All of these things down the road will alter, and that comes from the mind. Now, depression, from uh, great books and in the clinical space, is a condition, it's a medical condition that leads to a point where the individual has persistent feeling of sadness. And that sadness leads to a point where the individual will fail to recognize or pick interest in pleasurable things or even activities to the point that it begins to really affect how that individual operates in the society where the individual operates. Like I said, it happens across all ages, and it happens uh, to a point where that individual's functionality is affected. Signs and symptoms, like I said, persistent. And when do you begin to say somebody is depressed? You tend to have, one of some of these feelings for at least 2 weeks, where you feel so, a whole lot of sadness. You feel worthless. The individual has problem with even sleeping or even eating. And some of them is the opposite. They overeat. And some of them begin to lose weight, and some of them would have issues of operating on a normal function that they usually operate at. And if those things begin to go on for 2 weeks, that individual needs to begin to seek help. And when I say we'll take a primary look at this, the word primarily meaning from the medical perspective and from our own perspective, a primary go back to the basics. Now, a primary approach to this, when that individual comes in with persistent feelings that last for about 2 weeks, and you need, who's the first person for you to contact? Well, usually it will be a family member who would recognize this or the early signs. And, across ages, they're really different. And I'll take it a little bit. Being a pediatrician and adult doctor as well, we see some of all these things. And we need to recognize these things in our homes as parents, as guidance, as people who are custodians of other people's welfare. We need to begin to understand this so that we can intervene early enough to save lives. Why is it important? Because when depression goes on persistently for a long time, it's a paramount risk for suicide. So depression or sadness persistently leading to depression can lead to suicide. And that's why it's important that we begin to identify it early and intervene early. So if a family member begins to see these early signs, depression, feeling worthlessness, don't want to go to work, or school performance, and all this is begin to happen, it's time to actually sit and ask, are you okay? What's the problem? Not in a judgmental term or form, but seeking time where the individual would most likely want to listen and talk to you. Because sometimes they don't want to talk at that point in time. And I mean, for those of us who have teenagers in the house, and they don't want to talk, that's not the last time. That's the time. Yeah, that's one time you don't want to talk to them because they don't want to listen to you. And because often enough, a lot of parents, they're so used to, dealing with the child at that age, at the tender age, even from, from toddler to, a young 5, 10, 20, 15, and then the teenage age, and they begin to, the kids begin to feel like they've bombarded them. And that's why when they talk, it comes out here and it comes out the other way. Because at that point in time, the teenager himself is trying to figure out exactly, like one individual told me, I said, oh, you're 28 now. She's like, yeah, doc, I'm 28. Gosh. I said, how does that feel? He said, a whole lot of responsibility. Now I begin to think about what is my role on this earth? Why am I here? What's my purpose here? And these are things that preoccupy the mind of young ones. And a lot of parents don't know that. And then if you go back, think about what you felt when you were that age. So that even if you want to interact with somebody who you feel the mood, the attitude, the perception, and the interaction is changing, you begin to know how best to interact and engage that individual. Because otherwise, it becomes counter productive. Now, the next step is, of course, and you guys will hear me say this all the time, your primary care physician. Your primary care physician, it's important. And I look, for everybody who's here, and I've said it on this platform before, please get a primary care physician. You have to have one. You have to. You have a tax man for your tax. You have an electrician when something happens. You have a favorite mechanic. And you don't have a favorite doctor, a person who's a custodian for your health. And we saw what happened with COVID. The whole world stopped when the whole world was sick. And I always tell some of my friends and even patients as well, I said, listen, if you get sick right now, everything stops, including those who care about you. They will stop. So health is important. And COVID showed the world that health was important. I mean, those who were sleeping in church or the mosque every day couldn't even go sleep in the church or mosque anymore. They were home. They were stuck. And that was an issue that led to, anhedonia, loss of interest in pleasurable things, dysthymia, a precursor to depression, and even depression itself. And God forbid, for some who even led to suicide, and the whole conundrum of things that happen. So get a primary care physician and have this discussion. Now, the primary care physician will be able to screen you, because a lot of the time, I mean, we're all doctors, for God's sake. I know some of us don't even want to pay attention now. I have anxiety. Oh, I hear psych. Go. And guess what? In our community, we don't have enough psychiatrists. We really don't. And God bless us, Black psychiatrists for the matter. We don't. I mean, I have a difficulty finding psychiatrists around, irrespective of what race. We don't have them. And the ones we have, they're so overwhelmed and burdened with the whole thing. But thank God for those who are filling in some of the gaps, which are the nurse practitioners, who are doing psych. But God forbid for those who are going to psych because there's nothing else, they just want to make the money, but then that's a different story. But irrespective of what it is, the primary care physician should be able to see signs and symptoms. If it's mild, moderate, or severe depression, to the point where it's called a clinical depression, where you need help and you need intervention. They'll be able to help put you, they can put you on an antidepressant early and keep you, in tune with making sure that the signs and symptoms before things go really out of hand and you fall off, the bandwagon, like they always say, or even before, because sometimes you may see a psychiatrist in 2, 3, sometimes even 6 months. That's where they get the referrals, and they never get one. And for a young person who is at risk, it can quickly go sideways. And before it really gets to a point where people actually seek help, it's almost like diabetes. It must have been smothering for the longest time. And like, oh, it's just going through stress. Oh, it's just one thing or the other that's causing it before parents or family members really begin to seek help. Just like diabetes, it's been smothering for a long time. And then the signs and symptoms begin to manifest, can pee or peeing too much, or, you're losing weight. Same thing with depression as well. So early intervention is key. And because we don't have those who are in the primary field, in the space of psychiatry early enough, it's important that the primary care will have to fill in those spaces. And that's why I can't overemphasize it well enough, that you ought to have a primary care doctor who who you're comfortable. You should be, just like you're with your mechanic, just like with your electrician, the same thing with your accountant. You should have good discussions. And I'll tell you this, look, you may actually have to set up an appointment to meet with the doctor, not necessarily because he's going to tell you you have a headache or what. No, just have issues that concerns you that you want to discuss. And that's why it's important. Now, like I said, the signs and symptoms, areas where you have problem with, severe sadness, anxiety, even fatigue. You just don't feel strong. You can't move your body. You can't do anything. You may feel cold all the time. You may feel a sense of worthlessness, of guilt, out of the reason, from nowhere. You can't sleep. I mean, you have a problem, apathy, loss of appetite. These are some of the early symptoms. Like I said, if it persists for about 2 weeks, that individual needs help. Now, breaking it down by age, young kids do get depressed. You see them sometimes they're clingy, they're clingy, or they something's going on, they cry all the time, or they no longer want to eat the way they used to, or they're losing weight, or you see them, they don't want to go to school, and all of these things. These are signs in young age group where depression is beginning to be an issue. And sometimes a child who's not wet in bed, all of a sudden begins to wet bed. These are issues that are coming up. And you need to have an intentional sit down and a love and, fatherly or motherly love, or great sense of concern and love for that individual or that child, to tell them, listen, and ask what's going on. Irritability. They could just all of a sudden be irritable. No reason. You're like, oh, this was a good child. I don't know what happened. All of a sudden, the child is irritable for that. Anything you tell him, he's throwing tantrums. Something is brewing, and something is beginning to happen. And they may worry out of context from, what is ideal that of your child, or begin to pick up behaviors that is unwanted. Now, for teenagers, same thing, irritable, areas where they feel guilty, or begin to self-doubt, and all of these things come as well. And for those who are at school, you see them failing in school, or they refuse to go to school. These are some of the issues that happen in teenage age, or picking up using drugs, alcohol. These are some of the early signs and symptoms that individuals who are depressed in the teenage age group begin to manifest. And these are things that we must begin to pay attention as well. And of course, we talked about the adults, the same thing, worthlessness, self-deprecation, and all of those things that take place. Put together, it's good to identify some of all these things. Now, what are the risks? Huge. Age is one. For those who are older, they're more at risk of falling into depression for a whole lot of reasons. Either they regret some of the things they failed to do, or some of the things that they did, they're paying for. Or all of a sudden, the power that they had, they no longer have it. I mean, age 65 and above is much higher. And of course, the brain itself is changing as we grow older. Because for those who are depressed, we begin to realize that the brains of those who are severely or clinically depressed are even getting smaller than usual, because these are changes that begin to take place. either because the blood flow within the arteries in the brain is compromised, or inflammatory changes that are taking place is making the brain smaller. And that physical manifestation, when some of the MRIs have been done over years, to see that those individuals who are depressed tend to have a smaller amount of gray matter, or smaller volume of the brain. And of course, as you grow older, the brain volume begins to shrink as well. Is that a risk? Yes. Other social issues as well may add to that. Sex. People who are young, females have a higher propensity for depression than for males. Now, when they talked about race, like I said, it common in every race, every creed, everybody else. But those who are Hispanics, especially in the young Hispanic age group, they are more at risk for depression than Blacks. The prevalence is about 10.4 for Hispanics. For Blacks, it's about 8.9, and for Caucasians, it's about 7.9. That's for the age group, for risk of depression. However, in the overall big space of it, Blacks and whites tend to be almost about the same, but nevertheless, we know what's happening with research in our Black community. Maybe it's underrepresented, but then you tend to have a higher percentage of those who are Caucasians than Blacks. Now, other issues that can come up as well is health issues for those who get sick from cancer or from chronic debilitating disease. I mean, from younger age group, example, sickle cell. I mean, even the parents who take care of children with sickle cell know the feelings that they get when they see their children suffer like that. Now, if you take on the child who's had repeated bone crisis and pain and hospitalizations and blood transfusions and medications from a younger age group, all through to become teenage age, it's disheartening and it's troubling. So these are the things that put people at risk. Chronic debilitating disease, even diabetes in a young age group, even becoming a teenager alone, it's enough that adjusting the social, economic, and political structure around them as they adjust into adulthood is hard enough. Now, adding on top of that, chronic medical issues, it's a double whammy. Now, of course, those who've had trauma of every kind, from rape, from molestation, emotional, psychological, trauma. Those are the issues that can predispose you as well to depression. Now, loss of loved one, mom, father, child. These things affect individuals who are at risk for depression. Homosexuality has been recorded to be a risk factor as well, because I mean, now things are a little more open, but there are people who are still in the closet, still haven't come out, because they can never truly live to become who they really want to be. And these are issues over the years that seems to put people at risk, and a whole lot of other issues that are going on. I mean, we talk about trauma from those who war, PTSD, and all that and all that. I'm sure questions will come up. I'll begin to take each and every one of them as we go on. Now, globally, who are the people who are at risk? Same thing, like I said, but it's been said around the world, no particular numbers, but about 5% of the global population, which is about what, 7.8 billion people right now, 5% of them have depression or have suffered one episode of depression or the other. You can imagine what that number is. Do the math. And here in the United States, the same thing. I mean, in 2020, in fact, the incident rate per year, every year, is about 3 million. Every year, about 3 million people are diagnosed with depression. Now, on a prevalence, as we said, in 2020, there were about 21 million people who were diagnosed with depression. But that number, which is about what, almost 10% of the population, and today that has dropped to about 16, 0.9%, which is a huge drop. Most likely because of what happened with COVID, where the whole world was, very chaotic and people lost jobs, and of course, there's a whole lot of people who lost family members, lost the properties, and a whole lot of things. And that increased the number of people who were depressed. Now, if you talk about depression in, the here in the United States, we saw what happened with COVID, where especially among the, teenage age group, we had a whole lot that was so much more, to the point where, especially in Blacks, young Black men had a higher rate of depression, even onto suicide, than any other race in this country. Now, that is depression itself. And I'm sure questions will come up, and we'll dive into it as we begin to discuss a whole lot more. Now, coming to suicide. Now, this is one of the most devastating emotional turmoil that can happen to any family member, where the person who decides to go on to take his or her life must have gone through a whole lot, to the point where they feel so worthless and have no control over their life and have no control over anything else, that the only way they see out of what they see is to kill themselves. Now, but before people go there, again, we talked about healthcare and the management of depression and the different medications that are involved in the utilization, so that people do not get to the point where it's terminal. Terminal meaning they get to a point where they see suicide as the only escape. So early intervention, medication, psychotherapy, and all of that. We can talk about those questions and the different classes of those medications as we go on. But suicide, huge. And for those who are left behind, there's a pattern of which they go through as well, where in the mind, they begin to feel guilty. What did I do? How did I contribute to the point where my child, my daughter, my mom, my uncle, somebody else, a friend committed suicide? Were they early signs? Should I have done something? Should I have intervened? What would I have done? And the guilt even live and linger with them, even to the point themselves, they become depressed. Now, talking about things that are lingering, the depression run in families, yes. It's been said that depression can linger in families. The people where they have a higher risk of depression can link on to a higher risk. I wish that a whole lot of people still trying to look for the particular gene that determines if one family or one person in the family have a higher risk of depression. We haven't found that yet, but the only thing we know that there are chemical changes that take place, like I said, in the brain, where because the brain is full of chemicals and also filled with what? Electrical impulses. So you can imagine if some sparks take place, either from a disease or from infection itself, affects a certain part where the synapses and the electrical impulse that's supposed to go from one place to another is missing and mistouching. These are some of the issues that can result in depression, and even to a point where it becomes so quickly spiral down to suicide. Across the globe, there are about 704,000 people that have been described to commit suicide every year. 704,000. That's a lot globally. Now, here in the United States, about 45,000 people have been said to commit suicide every day. But there are a higher number of people, about 2.5 million people who are at risk, who have attempted to commit suicide. And a whole lot, much more bigger than that. Those who commit suicide, the risk is higher in females than men. But a lot of the time, some studies have shown that in women, it is more like attention seeking than anything else. Something's going on in their life. They want to get family members' attention. They do certain things, and they take pills. Either they slash their wrist and other things like that. But in men, it's a whole lot more definite, where there's an intention, and they often carried out with very violent forms, like guns or hanging and stuff like that. But unfortunately, we begin to see a whole lot of young, girls as well, who are resulting to hanging, and that is bad. It's devastating. And what are the risk factors? Again, depression, uh, chronic medical or terminal disease where they see nothing else, drugs, alcoholism, genetics. Um, the risk is much higher in Native Americans, followed by Hispanics, and of course blacks, and then Caucasians. But overall, in the younger age group, but overall more in the Caucasian. Now, country by country, South Korea has been said to be the number one, about 23 per 100,000 cases per year, South Korea. And the only other country that follows within the African context is South Africa. I think it's about 18 or 19 per 100,000. Here in the United States, it's about 13 per 100,000. So those are numbers that begin to come into play as we see this. How much is it costing? A whole lot, a whole lot. You can't quantify emotional, economic, and the whole drain on the family. What again do you need to do? Early intervention. Now, we also know, if I revert back a little bit to treatment, early intervention, depression, intervening early. Now, for those who are depressed, especially young kids, we've got to be careful. And studies have shown that if you put them, young kids who are overtly depressed, if you put them on certain antidepressants, then for some reason the chemical flow, because what happens is there's a reuptake within some of the synapses, because those receptors, the blood medication block certain receptors, so you have a reuptake of those chemicals, the dopamine, the serotonin, the norepinephrine. They are reuptake into the brain. The individual, the young adult or the young teenager begins to have a whole lot of energy, and that energy can push them to a point where they even commit suicide. So for those who are at risk severely, they need to see a psychiatrist so that they'll be closely monitored in a multidisciplinary space, so that those children who are put on those meds you do not increase the risk for them to commit suicide. So coming down, like I said, to Africa, those who in the African continent, South Africa has been shown to be the only country at that top, 15 number for countries that commit suicide. Now, in our homes, and these are some of the things we begin to come back home and begin to have a roundtable talk, because in our community, the Black and brown community, especially those Black community in this country, and I'll split into two forms. Those who were here, I'll use the word, whose ancestors came here 400 years ago, as compared to the immigrant community who recently came here. There's a whole lot of dichotomy in it, and how they approach the family structure and the dichotomy of how things need to play. There's a structure within the African American community and how they address issues, and it's a bit in between, the Western style of living and a little blend of the African American or the African context, and that blend is still really being taken care of or deciphered at the point where it's hard to tell which and which, or where they need to go to, what they need to do, because in as much as they live here in the United States, they don't have access to the resources as much as anybody else should, and they don't have the emotional and institutional backup to help sustain them in a society like this. And those institutional backups or the institutional oppression that's taking place has caused a whole lot of issues as well here that has put a lot of the kids here and their parents and driven them to certain things, whether intentionally or unintentionally. One of the biggest issues we found here in this country from way back in the 60s is drug addiction. Big issue here. Has that eroded the resilience that a Black man has? That's made him to a point where suicide and depression wasn't an issue they talked about. Because again, and that's why I draw a little parallel between the African American and those who are in the continent of Africa. A little parallel, because in both societies, depression is not talked about. It's swept under the rug. If you talk about it, it seems like you're weak. And that's how it's viewed. So because of that, we suppress it and repress it, either for a whole lot of reasons. And we can take it from either end. The same thing that happens in those who actually migrate here as well. There's a migrant mentality and depressive tendency that actually happen, where loneliness, the struggle to fit in, adjustment behavior, and risk factors put them at risk for depression that a lot of them don't even identify. But where they see that, they see it as a drive, the drive to succeed. And that's what often pushed them to a point where, yeah, truly a lot of them succeed. But guess what? A lot of them are dealing with demons within themselves that's really beginning to manifest in our community, where we're having a whole lot of suicide by homicide in the immigrant community as well. So these are issues that begin to deal with. Now, if you take it back 300, 400, 500 years back, I've often heard here in the United States where our brothers who left 400 years ago say, oh, you know, was it going through the whole horror of slavery and Jim Crow and segregation and all that. And you who are in the continent, you sold us off out. And that's why we're depressed and we're going through what we're going through. And we haven't adjusted. All right, I hear that. We feel that. But I've always asked, and I said this as well, people don't understand that those whose kids and brothers and sons were taken away from Africa also went through a different kind of trauma. The mothers who were left in Africa, the fathers who were left in Africa, they went through their own kind of trauma as well, depression. Only a mother whose child is dead or a parent who lost the child will understand the pain that they go through. So those who were left in continental Africa, whose children were taken away, those mothers never went to their grave happy. And those things had psychological effects as well, as much as those who were here went through the whole psychological effect. Those who were left in the continent went through the period of imperialism, colonialism, and even the segregation and degradation that's still going on in the African continent today. So on both sides of the aisle, depression was paramount. But what they did was put a wedge as well between both ends. And I think it's time that we begin to reconcile this issue so that we will see both sides as one side of the coin and begin to understand that we must heal and we must heal together. So I'll leave it at this point. I will begin to take questions as we go. Thank you and God bless you.
Wow. Thank you so much. And the note you concluded your talk is so important because we really need to bridge that gap between us and those who were brought here. Thank you so much. I just wanted to, add something. Dr. Aluya, thank you, because you spoke English. and I think we understand very well what depression is. But I wanted to say something that people usually have the impression that depression is something like, high blood pressure, your blood pressure is high, or you have diabetes and it's diagnosed. It's a constellation of symptoms. Like Dr. Aluya said, sad mood. Somebody is sad most of the time. They could be agitated, yes. They don't have the get-go to do things they want to do. They have difficulty with sleeping. When you're not sleeping well, or you sleep 7 hours and you still wake up tired, or you're sleeping too much, that can go either way. Your appetite is good or is bad, that can go either way. You gain weight or lose weight, that can go either way. But the guilt feelings, poor concentration, you just can't concentrate like you used to. Your memory also is not as good as they used to. Please, like Dr. Aluya said, go see your primary care doctor. The problem we have in our community is that people don't want to touch this mental health issue. There's no way you can function in your best capacity if you have depression and you don't get it treated. And so, Dr. Aluya, thank you so much for boldly addressing this issue that in our community, people don't want to talk about. It is very important that we address it. Madam VP has her hand raised, so I'm going to have her ask a question instead of asking you. Why?
Yeah, thank you, Dr. O. It's more of a comment. Dr. Aluya said, if somebody is going through stuff, you have to show them the best kind of love. I can't paraphrase exactly the way he said, but the word love, that is the most important thing. Because if you don't know how to love on that person, you're using a standard of a black man, white man, pink man to judge your child, your mother, your sister. You're going to miss it. And if you don't love on that person, you can't get them to get the treatment that they probably need. Because it doesn't matter where or what culture it is. Mental health has its own stigma that goes with it. And I think everybody has a level of mental health, whether diagnosed or not. So the presentation of your intervention has a long way to do with the person's admission and the recovery. There are some, professionals that they don't know how to talk to people. They talk to some of those people as if it's your fault, you're in the condition that you are. Some professionals don't know how, and that is probably why some people feel more comfortable to go and talk to a psychiatrist, because that psychiatrist is not going to judge you. But every case does not need a psychiatrist. So love on your child. The scary part is the suicide. So Dr. Aluya, I want to ask you, because you said mostly female. Female have, issues and stuff. How, I don't know if you are able to answer it, but I'm just curious, because this case has been rampant in our community recently. How do they get to that point of it's over? Is it because of rejection, or there's a chemical imbalance that drives people to that very last resort?
So it's, you see, the risk of suicide also has a genetic predilection as well. It runs in families, as we all know. And that's why back home, when you want to marry into a family, the elders will go into the family and go and look to see what's going on. And like, in that home, people commit suicide, they kill themselves, so don't go there. You understand? So, because even in our traditional way, we understand that. Have we been able to identify the gene yet? No, we haven't. It's still coming, but we know there's a genetic predilection. Now, for those, just like alcohol, for those who are at risk for alcoholism, because it's a risk of an addiction, We know that addiction is a phase and a genetic composition right now. And there are certain chemicals that are released at a certain age that once those chemicals are released at a certain age, when you are at risk for that, you are most likely to become addicted to whatever you're exposed to. The same thing with suicide and depression. So if somebody has a risk for depression, and there's also a code, a higher risk for suicide, not until that particular pressure that goes on to which is the they call it the nail in the hammer and the nail and nail and the hammer that drives in finally, it will never take place. So like you said, everybody has one mental illness or the other. It's just that it hasn't been defined yet. Or like an alcoholic who never saw alcohol, you will never drink and you never know you have an alcoholic problem until you get there. So the same thing. So if somebody goes on to be depressed and has maybe a huge support system or something that altered the course of that disease, rather than going left, it altered it to a point where, now move right. You met the right people, you met the right husband or girlfriend or boyfriend, or all of these things. Or you're a point in your life where, the job wasn't going on where you now got the right job and all that. So you tend to move on. Now, if that individual, for the smothering area where they go, now lose a family member, and then all of a sudden lost the job, and because they lost the job, they're losing the house, they're losing the family, and then the wife leaves him. You can imagine. So these are constellation of effects that just drives it completely, boom, where at that point in time, they just say, you know what, I have nothing left. I've had individuals who were doing fine, just managing on some meds or whatever, or just managing, like in addiction world, we say, functional addicts or functional alcoholics. They're just managing until something bad happens. And then they pick up the drinking. Same thing. They're functional depressed and they're doing well. And then they lost their job. And then, they lost the wife or something goes on, they lost the child. And then they're now diagnosed with chronic medical disease. And they're like, you know what? God hates me. My life is over. I'm just going to take it. So these are issues that take place. But again, for us to be able to help those individuals, it takes a whole lot. There's a spiritual component as well, where they need to seek help from a spiritual guidance. And I often say this, it's not about church, it's not about mosque, it's about spiritual connection, where irrespective of what creed you are, the most paramount thing that is unique to every human being, because God does not see Christian, Muslim, or whatever. He doesn't. What he sees is you and the spirit that he's put in you. You can connect with that person. You can. And that's why on a spiritual level, you can sit and talk with that individual and connect spiritually. You can drag them, if it's your church, if it's a mosque, or wherever, where you can have that spiritual bonding. It's not religion. It's a spiritual body. And you have to go on a spiritual course, a spiritual journey where they begin to reset. And that is one of the ways to reset those chemicals that have been denatured in the brain. And those chemicals, as we on a mundane level call it, they are dismutations. The chemical dismutation of certain enzymes and acetylation of certain enzymes. The names for the NMDM receptor, blah, 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 and all that, that controls serotonin and, norepinephrine and all that. A spiritual connotation can configure the genes that control those things. And that's why we know that even with diabetes, that the environment you live, the food you eat, and all of this can alter the way the DNA, it doesn't affect the DNA itself, it affects the way the DNA is expressed. So it's a phenotypical expression of the DNA. And that's what we call epigenetics. Religion, not just religion, spirituality can affect epigenetics as well, and all that.
Thank you so very much for that comprehensive answer. However, I want to say that Christ is still the solid rock. Foundation is important. However, it is very important. What I have seen that has helped in this people in this arena, in people who have depression or any other mental health issue, like you said, Dr. Aluya, support is important. You know, if you look at the profession that is most affected by depression, I know, Dr. Aluya, because of the audience, you want to make it general, you don't want to talk about it.
Right.
But I can't help it because we have a lot of doctors on this forum. The profession that is most affected by
Depression and suicide.
And suicide, yes, is the what?
Medical
profession, doctors. And if you look at the doctors, it would surprise you that it is those in community health, psychiatrists. I was going to leave that for the last. Anesthesiologists,
right?
Psychiatrists. Can you believe it? Psychiatrists, the ones that specializes in helping people, they have a much higher rate of depression than the other doctors.
And suicide too.
Yes. So what does that tell us? We need each other. I remember very well a physician who committed suicide. Do you know that 2 weeks before he committed suicide, a very close friend called him, also a physician. And you know what? They normally rap on the phone, they talk and, you know, and stuff like that. But he was quiet. His answers were, yeah, okay, yeah. His friend, who is also a physician, like I said, did ask him, are you okay? Are you depressed? And he said, no. But the friend did not pursue and he did not follow up. 2 weeks later, the physician, who is also a minister in his church, who is not is anymore, who was a physician, pillar in his society, has done so much, committed suicide. Please, when we notice a change in each other, you are not who you used to be. You notice that this person I talked to is not, the way they used to be. Please don't leave that person alone. Let's go after them. Let's be there for them, because you can be the person that will change that person's life. You can be the person that God will use to revert course that we don't want to happen. So
Dr. O.
Yes, ma'am.
I'm sorry. I mean, so in those cases, is that work burnout, or what could drive a professional to that level of no return? Is it work? I mean, because they always say in Nigeria, physician, heal thyself. So if you're saying that preponderance of these cases is with those who are supposed to be treating the issues, what happened?
Okay.
So I'll tell you this. People don't understand, and I've said it often enough, and I said it within the week, that I am one person who would never push anybody to medical school. I will never do that. Going to medical school is trauma. I swear, especially in developing countries like in Nigeria. It's one thing you go through one time and you never want to go through it again. From the psychological, emotional, financial, all of those burdens that they go through, it's intense. The same thing here as well. I mean, look at this right now. By the time they graduate, a lot of them are graduating with $300,000, $400,000 in loans. And God bless you, you marry another physician who also owns $400,000. So you have a combined debt of $800,000. Is that not trauma in itself? That's one. Now, the process of going through it, it's trauma where you sit down. There are times you feel lonely because some of your friends who you had through high school or college, because you went through 4 years of college, and most likely you did biology. So a lot of the people you hung around with may not truly be doctors as well. So by the time you come out and go into medical school, you're now sequestrating yourself into a particular group of people who you have to learn to readjust to. And they adjust to the work, the intense work, the demand, the pressure, all of those. On top of that, thank God for some of the changes that are happening here in the medical field right now, where the work hours have been changed, so that, they give you enough time to break. Back in the days, there was nothing like that. You work, you come to work. I remember as a young doctor, I went to work on Friday morning. I never went home till Monday evening. And you're all in the hospital, barely eating and all of those. So all of that, the trauma of going through that. And some people even forget as well, having to deal with cadaver or dead people that you have to work on and cut and all that. That has its own trauma. So a lot of these young kids who come into this space may not be emotionally prepared for what they're going to face or see. So over time, there's repeated minute trauma, small trauma. The same thing that happens with people who have chronic high blood pressure, where there's minute, small stroke. We call them vascular changes, right? That's what we call them. There are vascular changes in the brain, tiny strokes over the years of decades. So doctors face that too. And you never can tell who is coping well, who's adjusting well. You never really can. And that's why when your child comes back from college, especially those who are in medical school, you see there's a change in that individual. You may, it's school, he wants to take his time. No, he may actually be going through the trauma of adjusting to what he's facing and what he's going through. So all of those professionals who eventually commit suicide, like footballers, until we knew that those repeated trauma that happens in their head result in things that eventually will kill them or result in post-PTSD and issues of committing suicide. A lot of them, we didn't know that. So has anybody actually sat and looked at the PTSD that doctors go through? We really don't, because we just assume that you're supposed to adjust, you're a macho man, you're this. Not everybody is fit for that. So these are some of the things that take place to a point where by the time they finish medical school, they graduate, they look, some of these guys go to work at 6 o'clock. I remember as a resident, I was at work 6 o'clock and I was raising my child. I have to drop my child off at the daycare and be at work at 6. So you can imagine when I woke up and I have to study.
Depends on your rotation, no. It's when you
depends.
Surgery and OB. Surgery and OB. We have, Madam VP, this is the thing. Doctors have a tough life that most people don't realize or appreciate. Yet, picture a day in a doctor's life. They said community health doctors, psychiatrists, and general practitioners. People come and dump. They have different issues, right, and they dump. If you don't have an outlet, I will repeat, Jesus is the solid rock.
That's it.
If you don't have an outlet, it will catch up.
Yes.
And not only that, you go into practice, right, you go into private practice, and you see a patient. Look, some patients come, they have need, and you have to spend the time to listen to this patient in order to make diagnosis and to intercede. You see the patient and all that, and insurance turns around and they pay you $76. The reimbursement has changed. Insurance companies run medicine. Right. You prescribe medication to patients. That's the medication your patient needs. And insurance companies refuse to approve it. But patient comes on you. You didn't send my medication. Pharmacists said they don't have it. I don't want to go through the doggone process that doesn't allow the patient to know that the medication was sent electronically, but insurance is the one that don't pay. Everything comes onto the doctor. The stressors are multiple. So move beyond medical school, your young graduates, even in the young force, it's different. And for those who are even working for people that are not in private practice, the demand is incredible. Now they're actually paying people by, they have a name for it. What is it, Dr. Aluya? RVUs. That's paying you per how many patients you see or what you did. And you are not in charge of bringing those patients in. It's the patients they bring into you that you see. I can go on and on. Dr. Aluya can go on and on for space of time.
They do the same thing to us.
We have hands raised.
Right. And the law. I'll tell you this. You see,
so I just there's a hand raised. I want us to move.
So, but let me talk about this and how important this is. And we talked about repeated trauma that's taking place over decades. And then you lose a patient. The loss of a patient, especially a patient who has become a close person or a close friend of that doctor, you lose them. Something is missing somewhere. These things happen and it's frustrating. I'll give you my example, typical example recently, where a patient who I know very well, she is a highly educated Black woman, an executive at the university, and called me like, "Doc, I've been having this pain. I'm having this pain." So I said, "Oh, well, it's a weekend and this is what's going on. All right, fine. Go to the ER, because at the ER where she worked, because you work there, they know you. So they most likely would, take care of you. And I know they'll do a CT scan." She got there at 11, sent me a text. I said, "Okay, fine. Let them do a CT scan for you." She got there. She's a very sweet, very calm, lovely lady. An entrepreneur with multiple businesses. She went there, sat down, and the whole ER was going crazy. They didn't see her until she made a fuss, like, "Oh, we forgot you." And then they started doing the blood work. They did the blood work. By the time it was 8 o'clock, they're like, "Well, there's too many people here. We can't do the CT scan now. By the time the result comes, you take her and you may be here overnight. Why don't you just go see your doctor?" And she came up to see me. So she came and she had seen the GYN. The GYN said, "Oh, what she has most likely is uterine prolapse. Is uterine prolapse, that's what she has." She said, "No, this is not uterine prolapse." So she came and did an ultrasound. Did an ultrasound, came back normal, everything fine. Went back to the GYN, she was still in pain, and I asked for a CT scan. The same day I asked for ultrasound. I got the ultrasound because I know they won't do it. They rejected the CT scan. When she went to, and this is again, racial disparity when it comes to some of all these issues. So she went to the GYN, the GYN still think, "Oh, it's a uterine prolapse." So he sent her to a urologist. She went to a urologist. The urologist, who is in a different zip code from our zip code at the hospital or the university where we are, said, "Okay, I want a CT scan." Guess what? They did the CT scan immediately. It was approved because it's a different zip code. That's a different story from another day. This is happening less than a month. CT scan come, results come. They said she has ovarian cancer with some meds. You can imagine how devastating that is to the woman and how disheartening it is for me, who had asked for a CT scan that was rejected by the what do you call it, the insurance company. So God forbid we lose that woman. You can imagine what that will feel to the individual. So these are issues that all put together that can drive somebody, like they say, to drink. God forbid we drink.
So thank you so much, Dr. Aluya. Thank you. Dr. Adewale Okpeyemi, all the way from Nigeria, kindly unmute. I'm so sorry. I know you've had your hands raised for a long time. There you go. Thank you.
Good evening, good morning.
Can you increase your volume for us a little bit? Speak a little bit louder, please.
Okay. Can you hear me now?
Somewhat. Yes, barely.
Thank you very much
Fantastic. We can hear you now.
Thank you, Dr. Aluya, for your wide experience about this topic and the data, the statistics you have given is so alarming. I just want to, I have two questions, but before I get to those questions, there's some foundational truths that I think they have mentioned that you need to emphasize. The issue of things happening generationally. Let's say I found out that okay, there are some things that if it happens in the father, it will eventually happen maybe in children to a certain degree, but they may not really be able to know why it happened, but they find out that there's preponderance instead. And then the issue of depression and suicide is actually one of them. The question that I want to ask for for teenagers, the role, maybe from experience, what's the role of the antidepressant in teenagers? I had a experience, I witnessed a case of a colleague that his son was about committing suicide recently. Early this year? Yes, early this year. The guy the guy had a very good, brilliant result at the level of jam.
You are going in and out.
Oh,
Right.
maybe
Yes,
my
okay,
network.
Yeah.
Are you hearing my audible now?
You are audible now. Yes.
Okay.
Thank you.
So the role of antidepressants in teenagers.
Okay, we got that. The role of antidepressants in teenagers. So what's your other question? Is it the generational occurrences of mental health?
No, the other question that I want to ask is on the issue of the advent. I want you to address the issue of advent of technology and social media in the prevalence of depression and all these suicide. Because we are now in a part of the world whereby we are doing everything is being done for us. People don't even think about things again. Before you know it, Google, you ask me a question, I don't know, Google is the answer. All these things, does it affect the way human thinks? Does it affect human mind?
Okay, so the first question is the role of antidepressants in teenagers. Dr. Aluya. So we have lots of questions in the chat box also.
Right. Like I said, like I alluded to earlier on, when you have a teenager, especially a teenager who has gone to a point where it's clinical depression, meaning severe depression, that individual needs to see a child psychiatrist who are specialized in these areas and they know exactly what to do. And, they take it steps and they understand the dynamics on how to do this. And of course, antidepressants are great because they help to rebalance the chemical imbalances that take place in the brain. But it's not just that alone. They also do group therapy, psychotherapy, one-on-one sessions, all of those. And these are people who need to be seen frequently because for them, especially those who are at risk for suicide, the paramount pressing issue that put them in depression are usually environmental social stressors, problem of adjusting to situations. There's what they call adjustment disorder, anxiety. And these are issues that predispose them to depression that eventually may lead to suicide. So you begin to address some of those issues and as I say, get into their minds and their brains on how to handle and resolve some of those things and give them support and show that
so to piggyback on that, how does technology interfere in mental health of teenagers or our youngsters today?
Right. Two ways. I'll say this, especially during the COVID. One of the things that we talked about in one of our forums that you know of is this, especially when COVID took place and everybody was now, sequestered at home and the kids were at home, no school, no human contact, not even with their parents or grandma. The only access they had to the world and to their friends was through their phones, technology, social media. So at that point in time, we and some of my friends, and especially even the psychiatrists, I said, look, this is not the time to take away your phone from your child because that's the only escape that they had so that they don't go crazy at home. So yes, it was the only escape that they had. So you couldn't take it away. Otherwise, things go really south from there. Now, before COVID and everything else, and that's why in television, you see parental guidance, you can time it and all that and all that. So yes, the internet and all that, social media, the age group where you begin to, allow them to get on social media or have their own phone, and even if they do, what are they doing on social media? What are they watching? What information are they exposed to? I mean, if they're bombarded with the whole issue of what's going on, I mean, look at Ukraine. There are young kids who are troubled, so troubled with anxiety to the point that they feel they're going to die and the bombs they're going to throw will get to the US. And they're anxious about it, even adults. So that information overload can be detrimental to their psyche and emotional well-being. So you have to learn to, manage that and handle that problem. Now, the issue that we were dealing with before was cyberbully. For those who were on the internet and all that, they get to a point where they have friends who not just bully them at home, but even bully them at on the cyberspace. And you have adults who, for some mechanization, do some devious and terrible things and go online just get the pleasure of bullying people and bullying young kids as well. So that's why it's important by the time you begin to see this, that one of the first things you do is address the issue, take away the phone from them or take away or limit access to them or limit to the websites. And even if they have to do it with them, especially if they're really young. For adults or the teenagers, yes, they may have to take time off from it.
Thank you. I hope, Dr. Opeyemi, your questions are answered. Before we go into the chat box, I saw my sister Rosemary, you raised your hand, and being in this space yourself, I know you probably have a comment or two to add. Please come on. Thank you.
Good evening, everyone. And Dr. Aluya, thank you very much for that brilliant presentation. I just want to comment on the love aspect of it. I think we all take love for granted. Every one of us need love. Even, you also talked about spirituality. Extremely important because I'm a faith-based clinical counselor and a life coach. So I deal with my clients, through the Bible. And when you talk about love, because 1 Corinthians 13 said that if you think that you have everything in this life and you have no love, you are nothing. If you give everything that you own to the beggars and you have no love, it profited you nothing. So we need love in our lives, just like we need to oxygen, So life without love is nothing. So Mr. President, Miss President was talking about, love. Parents, a lot of parents, especially people from Africa, they never taught them about love. They never received love. So how can they give love to their children? You can never give out what you don't have. So that is the biggest problem. And a lot of times when these kids are misbehaving, all they need is just love. That's all they need. Validation from their parents. When they have depression, the parents will say, oh, what are you depressed for? You don't pay no bills. Mm-hmm. You don't do this, you don't do that. Come on. let's, let us keep those things apart and know that these children are facing bullying outside there. They are facing two different worlds. When they are home, they're Africans, and when they're out there, they have to act like Americans. They are confused. So we parents have to be very, very sensitive about that. So that's my comment right now. Maybe later I can say something else. Thank you.
Thank you. So true.
Yeah,
I see that a lot in our African American communities. I see what you just described a lot. Yes.
To add to what she said, it's profound. And one of the things that we, as adults that migrate from other countries here, we also seek validation. And we sometimes we pretend like we don't do that. We seek validation to a point where we want to adjust and we want to get acceptance into it. And one of the things that we also do that we don't know we set our children up for a lot of emotional turmoil. And I've heard parents proud. Oh, you move from the neighborhood where people know you and all that, and you move to another neighborhood. It's predominantly white. And then you're proud. Oh, my child's the only white black kid in the school. You think it's a thing of pride. Lord have mercy. You don't know what that child is going through in that school, where the child will begin to hate his or her color because everybody around them is white. I mean, look at the 10, 12, 13, 15-year-old who's just trying to know where he or she belongs in the world he's going to. And is thrown into the wilderness where people make fun of the color of his or her skin. And the way we raise our kids at home, it's not the way they raise their kids.
Yeah.
12, 13, 14, 15-year-old, they begin to talk about boyfriend. It's okay, they date. Meanwhile, yours cannot date. You can't even mention boy, not to talk of friend at home. So it's the child is put in a mix where, like, and before you know it, the child is depressed. The first is irritability, oppositional defense behavior, truancy. All of these things begin to display itself. And meanwhile, you're proud and hitting your chest. My child's the only black kid in the school. Meanwhile, the poor child is going through horror of it. If they have a game to play, they take sides. They won't pick your child. The child is stand left around. I mean, I know somebody who drove around one of those towns. He said he was driving and saw kids hanging out. One year, he drove by, he saw it was only one child who was black, standing alone. All the other white kids were playing. The next year, he drove around through the same area. He saw two kids, two black kids. They were standing, and they were just standing by themselves. The other kids were all playing. And not just that, the differential treatment that even the teachers and the institution in the school, because they don't know who your child is. They don't know how to handle your black child with the culture that they come from. One of the worst things that will ever happen to a child is for the teacher to tell that child, you're not good enough. That thing stays.
Yeah.
And it lingers all through the life of the child. So when we decide what to do, look, it's always better. You put your like minds to congregate together. You can always, if you were raised in a Bulegba or in Ajegule, permit me for saying that, or area, and you turn out to who you are, Lord have mercy. You can raise your child in Detroit with core principles, raising them up from who they are, and they'll still turn out to be well.
Thank you so much. That is profound, what you just said. Rosemary, you wanted to say something else? Okay, good.
Well, I just wanted to say that a lot of the parents, do not even see the children when they are going to school in the morning. The children do not know how to put on deodorants or their clothes or anything. They go to school, the other kids will start mocking them in school. And parents are not paying attention to, to see how the kids are doing. They don't care about their psychological or their emotional, well-being. all they're thinking about is that, oh, she's making good grades. He or she, they're making those good grades for you, just to please you, you know? So everything boils down with, there's so much competition in our community. We should stop that, you know? For the fact that your child is going to a private school, you're going to be boasting around saying that your child is going to a private school, but that child is hurting, just like the doctor said. They're not feeling, I mean, it's a whole lot that is going on out there. I just feel that, I just pray that, you know, we African parents will become real with ourselves and stop trying to be what you are not, you know? Show your children love. Learn how to love yourself. Because if you don't know how to love yourself, there's no way you can be able to love your children or pay attention to them.
Dr. O, I just want us to come back to love.
Thank you.
We are lucky, those of us that are able to express this emotion to our children and say, I love you. We are lucky. Some people don't know how.
That's right, they don't know it.
They don't know how. We are using the standard of international community to define love. You know, in my growing up, my father never said, I love you, but I know he does. Because he would always rub my head, he would pull me to the side, you know, he would take a piece of meat from his mouth and give to me.
A piece of meat.
Yes, he would give me a piece of meat. He would be looking at my eyes and say, what's wrong with your eyes? You know, all of those things. I knew it. I crave for those attention. Some parents don't know how.
They don't know how.
They don't know how. Yeah. Don't know how.
So that's
please raise up a child that you would like to have a relationship with in the future.
Okay, so
well, I'll tell you this.
Yeah.
It's not as if we don't know how, but you see, for instance, here in the US, you know, Madam Lara, if you bring meat out of your mouth, out of love, and give to your child, he's gonna say, "Ew, what the heck is this?"
Exactly.
Okay, so
you know, it's a pattern of how you do it. Now, again, we have to learn that emotional intelligence, and that's what we need in our environment. And I guess we have people like, you know, Rosemary Weber and other people who are in that space who have to have a lecture to teach our migrant homes the emotional intelligence, because that's what a whole lot of us need.
So,
it's
Dr.
not that we don't
Aluya,
know it.
that was what I wanted to say.
Right.
It means that we really maybe don't know how. So I think we need to have a follow-up to this.
Yeah.
Because I want everybody's question to be answered. We don't want a myopic, you know, discussion. We need to have a follow-up to this where we focus on how, and maybe bring suggestions, case studies, and things we have seen or experienced, and then discuss them in order to learn. On the forum tonight, Dr. Aluya, I'm glad you mentioned, you know, people in this space. We have another sister, Omira Lee, on here, who is a counselor also. And I can see that she's listening very attentively. I think we should have a follow-up. So now just do how. However, let's go back to the questions in the chat box. You'll have more opportunity depending on time, so that, you know, we'll get everybody, we'll have an inclusive meeting. Thank you.
So we have one from Dr. Ajabe. What is the impact of socioeconomic marginalization on mental health issues as it relates to racial disparities?
Profound. Seriously. I mean,
see why I want the questions answered.
Profound. I mean, it's not one issue. Again, like I said, you know, and I alluded to high blood pressure. People have high blood pressure, and before they get to a certain age, and they now have Alzheimer's. You understand? Vascular dementia. There are tiny strokes that happen. So this tiny, tiny insult from wanting to get to school, you're qualified, you didn't get in because of your race. You qualified and you have the degree. You apply for a job, you didn't get it because you're female or you're black or you're not from the right background. All of those socioeconomic, or you are a doctor or you whatever, and you go into a store, you're not allowed, or the restaurant, you're not allowed to sit down there. Those are tiny, tiny insults that begin to build up every day. It's like a bucket. You put a bucket here and put one drop every day, one drop every day. Guess what? It is only one drop that will make it fill over and overflow. One drop. And that's that one drop that might result in suicide. But if that drop is stopped, then you may continue to linger around and smother on, even to the day that you die. You know, so that's how it is. It's profound.
Thank you. So we have Dr. Scholastica Ilogalu. Kindly unmute. I love your name. So unique.
Thank you so much. Good evening, everyone.
Good evening.
I'm Dr. Scholastica Ilogal. I'm not a medical doctor, but academic doctor. I've been listening attentively to all the discussions, even though I was sometime busy doing something else. Anyway, yeah, I've been, Dr. Aluya, you stated a lot of things that if each of those things can be discussed at different times, you know, that will help most of us. Parenting, education, prevention, a lot of things are involved in all this discussion. So anyway, I just wanted to say, to thank him for what he's been doing and all the participants. And also I made some, I made something in the chat where I talked about, there was something he said about the healthcare and how the services have been, you know, the doctors we prescribe and another insurance company we change and all that. And at the time they are doing all these changes, the person is going down and a lot of costs are involved. A lot of time are involved. A lot of other things are involved. And all this will bring back, you know, it's not going to give good results. So I just want also to show that there's a book I wrote, and it was when I saw all this in the health system that I tried to write that book. I did a research, grounded theory research, and I wrote and I put it in that book because nobody will hear me all over the world except it's in a book. So I just want to share this with you. Thank you very much. I appreciate it.
Thank you so much. I saw that and I took a picture actually in the chat box. Thank you.
Yeah, it's on Amazon.
Yes, thank you for sharing that.
Okay.
We'll definitely get that. And thank you for your contribution. You just echoed what I said. We need to have a follow-up, quick follow-up on this one. Dr. Aluya, you are stuck to talk about how, because we're talking about, yeah, this is a problem, this is a problem, then how do we parent? So we have to dialogue on how we would, you know, get that done. Dr. Busola George, kindly unmute.
Yes, please. Good evening, everyone.
Good evening.
Thank you, Dr. Aluya.
Good evening, ma'am.
Good evening.
Ma. Oh my God.
Good evening.
She's my senior Reagan.
Oh my God. Don't know what you mean likes. That's Molola. Molola is the one in Reagan, right? Okay.
Oh.
Yes. Thank you. Dr. Aluya, thank you so much. But I would say this, the topic you taught tonight is a very important one. And not all of them are important. But this is something that all of us have to ask ourselves, what exactly are we doing to our children? I always believe children live what they learn. And we as parents, we have a lot of responsibility, a huge one. Now, a lot of us, and I hear you say something about African parents. Yes, that's true, but it's not just African parents. All parents, white, black, purple, whatever color. If you do not have time for your child, you do not know your child. There are some of them, they call them helicopter parents. They go from one to another. They never come to the schools. They don't understand what is going on. They just want to pay the teacher or pay somebody to fix it. Children cannot be fixed. You need the time. You need their emotional support. You need to hear them. They need to hear you. And so when you are dealing with children, they are not products. There's an emotional attachment to every relationship, and that needs to be nurtured. And if we cannot do that, it's difficult. Also, when you're thinking about a child, a teenager, if this teenager is growing, there are many changes, like you said earlier on. However, you're looking at this child and you know that this is a critical period in the child's life. They need that support at that time. Also, we need to try and make sure we have children engaged in sporting activities or any curricular activity when they are able to relate to with other children. And then their self-esteem is so important, because our parents have to make sure that this high self-esteem, we cannot take it for granted. Because I remember growing up, I didn't feel I wasn't loved. Yes, you were spanked, it's okay. And it wasn't child abuse. So we went through all of that. At the same time, when you think about, you need somebody who will tell you, yes, you can do it. You can do all things through Christ who strengthens you. Go on and run that race. Go and talk to that girl. Don't worry, she likes you. She doesn't like you, too bad. It's her loss. You need somebody to tell you that you mean something, not just sit there and wallow in self-pride. In self-pity. So these are some things we need to be able to tell our children. And parenting workshops, very, very critical, because some parents don't know how to be parents. They think by buying them things in the store is what makes them the greatest parents. No. So let's just, and I'm glad that you are going to follow up on this topic. I'm very much interested. Thank you.
If I may add to that, and I would be firm at this stage, and I'm unabashful about it, and I'll say it straight up. Look, in a relationship at home and raising children, it is not 50-50. And our women need to understand that straight up. It is not 50-50. We come to this country and we think we want to equal it. No. I mean, as people who come and trying to settle down and build a home and build a structure, and the men are going through demands of wanting to succeed and be successful. And not just here, but also you have the family members that are pulling your strings back home as well. You must build a house, you must build a mansion back home. Now, it takes two to tango, they say.
Yes.
But it takes two to understand that the home here, first and foremost, is more important. And that's the advice I give to people when they come. I said, look, don't start issue of giving 1,000 naira to $1,000 to people back home, because right now you have no children, or you have just one child. By the time you have 2, 3, the demand is so much more. They'll be in school. You can no longer give 1,000. Then the next thing they'll say, now it's only 200 is bringing. It must be that his wife that's causing it. She's changing. But then, coming to the fact of on the ground, there has to be a sit-down discussion of the mother and the father of what roles each one has to play. And look, men are not wired. I tell people this, I'm a pediatrician and I'm very good with kids, but I'm not as 1/10 as good as the woman who doesn't know what to do. Period. Because we're not wired for that. That's not what we're wired for. We're wired for something else. And we need to, and our women need to understand that as well. Oh, it's your turn to today, carry Peking. I mean, you can help, fine. And you can help teach the man. And especially when the children are going to a point where they're beginning to develop that emotional, need and demand. At the point in time, they need their mother the most. And unfortunately, men are not wired enough again to the point where they get that emotional intelligence to deal with that child. And they need the mother. So that is not the point where you begin to play pity party and say whose turn it is at that time. No, your job at that point in time is to see that child is successful. Whether the child is a white child or a black child, this cuts across. And our women need to understand that. As a pediatrician, I see that all the time. I mean, look, a lot of the time, the people who bring their kids to come get shots up to say, look, I can tell it's 1% that are men. It's usually the mothers that bring them. because either because the men can't handle the blood or they can't handle how to take care of to tell this child, sorry. All they do is shut up. You understand? Because they don't understand that. And at that point in time, the mother's voice that the child has heard, even when he's in utero, is keyed into his genetics. And women need to understand that as well. And that's why when the mother talks, the child hears and understands. And I'll leave it like that until we continue with the next time.
Thank you. Thank you so much. You're right, Dr. Aluya. We do have aberrations. I know some men that, some aberrations, but it's rare. Dr. Booker, you've been raising your hand and putting it down. So you got the floor, man. What's my...
Thank you, Dr. Lou. I enjoy your lecture. I always enjoy your smile when you were talking. You know, something that wasn't mentioned and happened, my daughter's friend, a friend of a friend who from Tanzania committed suicide recently. He was a lawyer, big time, working in big firm, 300,000, but his parents wouldn't accept the fact that he's LGBTQ. So her friend got a text and he said goodbye. And before she could get over there, she saw the police. Then I was speaking to another cousin recently whose daughter was at Temple sharing a flat with a girl who disappeared. So I said, did they find her? Yes, she jumped over the bridge. She went home the night she was LGBTQ. I didn't hear you mention that, but that's the big thing now. And my daughter is saying, well, we do everything, people do everything, but the parents are not accepting certain things. And look, they lose their kid because of that. So I just wanted to mention that. And I must mention that anesthesiologists are one of the top professions who commit suicide because we have the drugs. You get a vial and there's always like 1/4 cc extra, and they just pile up that vial and they can get a good dose of some of fentanyl or some IV medication. And also talking about children in school, I remember coming from, my daughter said to me, oh, whenever they're doing this book, Scarlet something, and there was something about the Black woman, they looked towards her. And of course she wasn't raised in the typical way, and so I said, at first I didn't bother with it because, coming from Guyana, living in Nigeria, it's like, how dare him? So when she says, but you don't listen to me, I said, well, let me come and meet the teacher. We will see who will listen now. And she said, oh, no, don't come. So then I realized that these teachers just turn to the Black kids because they're Black and they think these kids represent all sorts of Black characters that the kids have never heard about. And that's what happens a lot in some of these private schools. But after a while, they knew me because I was a typical Yoruba woman. I'm not, but I was a typical Lagosian. So they knew that when I put my foot down and said, look, I will close the school down if you try it again. I said, you don't know me. I said, if my daughter commits suicide, this school will close down. And they look at me. I said, just remember on this day at this time what I said. So I don't think they ever tried anything again with her. Even in middle school, I teach her the right thing about the blood, the heart. And this guy who always picking actually said she did the wrong thing, like saying the blood, aorta carries deoxygenated blood. My dear, I went straight to the school. I said, if you keep this guy, eventually he got fired. But you have to stick it out in a nice way. And the thing is, when your kid comes in the car, the first thing I do, I look around and say, what happened? You could see it from them when you pick them up. Either they're falling asleep or they don't want to talk to you. And right away, you pick up something is wrong and you go after it. Oh, I'm sorry, the book I read recently about LGBTQ, I don't know if people want to read it, is All Boys Are Not Born Blue. And it just tells you of the life of an LGBT guy that he writing after he finished college. And it's rather interesting. I recommend it. Thank you.
Yeah, thank you so much, Dr. George. I actually did mention LGBT earlier on, and I said it was a huge risk factor for um,
For
depression
depression.
and suicide because a lot of them are still in the closet and they don't want to come out because of what the society or the space where they are would not accept it, especially in our Black community and in the migrant community as well. Black migrant community, and God bless you if you're from the Southeast Asia area or the Arabian Peninsula. It's incredible as well. So we've had a whole lot of people who commit suicide from that. But one of the things, I mean, look, again, how do you address that issue? I'll give you a typical example, and we'll take this example. So I had this kid who I know he all of a sudden said, "Oh, my name is Tanya, Susan. Call me Susan." And then he's like, "Oh, I'm gay. I'm all that and all that." And he was really pissed off at his grandmother because the grandmother never accepted his coming out or his lifestyle. And he kept on and on and on and on. And he came down one day and we started talking. I said, "Oh, my grandmother, I just don't know. I hate her, this, that, that." I said, "Okay, where's your mother?" He said, "Well, I don't, my mother left." I said, "What do you mean left?" "Oh, she dumped me and left me because he has some form of mental, physical challenge." So I said, "So who raised you up?" He said, "Well, I was raised by my grandmother." So I said, "From when you were a baby up to when you were 28, your grandmother raised you, right? And she loved you like, yes, the best love I can ever, raised me up and all that." I said, "How old is your grandmother?" "Oh, she's 78. I said, "Okay. So you think she doesn't love you anymore?" She's like, "Well, she does. I just don't like the fact that she can't accept me right now, disheartening and all that." I said, "Do you know where I'm from?" He said, "Well, I'm sure you're from Africa somewhere." I said, "No, I'm Nigerian. Yes, I'm African, but I'm Nigerian." I said, "Okay, have you heard about egusi and eba?" He said, "No, what's that?" I said, "It's the food we eat." I said, "How would you feel all of a sudden I ask you to start eating eba and egusi? How would you feel?" Like, "Hell no, I'm not going to eat that." I said, "The same way. Your grandmother grew up in the old school ways. And that's what she knows, that this biblically is wrong. So you waking up all of a sudden and asking her to eat the eba that you're not going to eat. How would you accept it? Do you expect her to all of a sudden start eating eba and pounded yam that she never ate all her life? Just like you would not eat the pounded yam and eba. So it's hard for her to adjust, to accept what you're giving her. And he sat down and said, "Wow, Dr. Aluya, you're right. I never thought of it like that." I said, "Yes, that's how it is." So I said, the only thing you need to do is one, you need to sit with mom and understand where she's coming from. She's loved you all her life, raised you all by herself. That love never goes away. So, but the fact that you are standing on a platform and you expect everybody to accept you for who you are right now, it's hard for her to accept. So he said, "Yes, I'm going to go home and I'm going to resolve this." And she went home, they resolved this issue, and he accepted the mom stand, the grandmother stand, and the grandmother eventually slowly learned to accept him for who he is. Voila, then came peace. So these are some of the issues that we face. It's hard for all of a sudden to reconcile our biblical background and what we've been taught for centuries. Living in a country where it's now accepted, and all of a sudden we expect to start eating lo mein and frog legs. No, it is hard. It takes time, and it takes reconciliation counseling, because the mother whose child is LGBT don't hate the child, it just hates the lifestyle, and that's just the way it is. And until you get to a point where it is facing you in the face and you have to make that decision, you will never understand what it feels like. Just like if you're in the house, you not know what the rain feels when you're standing outside until you are standing outside. And that's just the way it is. It's reconciliation and readjusting and understanding where each one stands and accepting it. And that's how we begin to move forward.
Thank you very much. Dr. Aluya. Lady Maya says a personal relationship with God is key. And Clem Banks responds, I know Jesus is the answer, but how can one explain the situation earlier discussed, the pastor doctor that committed suicide? How can such be prevented, or how can such people be helped?
I think that question was for me because, I will reiterate, whew, Jesus is still the rock. He will give you perfect peace if you cling to him. However, pastors, like doctors, pastors more so, everybody goes to them with their problems. The doctors too. Everybody comes with their problems. Dump on the pastor. They forget the pastor is human being. The pastor is God. That's what they think. We need to look at pastors differently. We need to look at our doctors differently, that these are human beings too. What we said before, that when you notice a change in somebody who is close to you or who you notice a change in them, in their behavior, in how they relate, you feel that there's something off. Don't leave them alone, even if they carry a title. Get close, love them by seeking to know why they have the change. Intervention is the key in preventing this. I have stories after stories that by the grace of God, the Lord has used me to intervene. And some people get on medications, counseling, combination, and they're doing fantastic. But without that intervention, the story would have been different. They would have committed suicide. Some were contemplating suicide. I appreciate Rosemary on the forum because I've reverted to her so many times. She can echo what I'm saying, how the Lord has done that. So I've seen it work. I've seen it change lives. When you take the time out of what you call your busy time and just give that time to appreciate people around you, to reach out, to just keep a filler out if they're different, if they're not the same, and intervene. And being there for people. We shouldn't be too busy for each other. Pastors and doctors, they're not different from other people. We all have flesh. And we all need
I think
Jesus.
one of the things is, one of the references that is if your patient is an atheist or is a Muslim,
yeah,
and how would you deal with that individual?
Excellent question. Excellent question. I have patients, lots of them, who are atheists. Me too, I've practiced Islam before. So I have nothing against anybody. And my patients will come up to be the first to tell you that. When a patient comes in, I address the need they have. I know that Christ is the solution to all life, but it's a choice. Christ is a choice. He didn't come here to force himself on anyone, and none of us should force him on anyone. He didn't send anybody to do that. But we all have free speech, I have the freedom to share where my strength is, and my strength is in Christ. And anyone who is interested in having strength like that, I'll be glad to share. However, when it comes to anything, any kind of disease entity, ailment, mental, especially mental health, will address the mental health. And my patients do fantastic. But it is noticing, even in the clinic, patients that one has known for a while, they come in and they're different. I don't let them go. I want to know the bottom. I'm going to get to the root of why today you're down. Why today you're not teasing Dr. O, because I love to be teased. I enjoy my patients. And so what's different, what's changed? And 100% of the time, people talk, and then we get help. I will step out and get counselor. I'll step out and get psychiatrists and make sure that we get them into the proper care so that, their needs can be addressed.
Thank you so much, Dr. O. And Dr. Opeyemi confirms that he says what we focus on and expect from various life activities majorly contribute to our mental health. Our spirituality is the backbone. Look into Isaiah 26:3. God will keep him in perfect peace, whose mind is stayed on him.
Amen.
Amen. Elizabeth Thornton says, when you have an older teenager, 18, who was recently diagnosed with bipolar, what is the best way as parents to support them? Medication and counseling are part of the current therapy.
Yes. As a parent, you have a whole lot to play as well. And that's the time you get closer to your child and sit and seek fervently what the issues are. Are the issues at home? Are the issues at school? Are the issues with the relationship, a boyfriend or girlfriend? Is there a bullying issue going on? Is it something you missed growing up? Because it may actually be manifesting, I'm sorry, I'm going to say this now, but the trauma happened 15 years ago. I mean, and I'm going to raise this thing up. One of the things that was shocking to me, eventually, when I spoke to some of my friends, I was shocked. And I'll take it this way. First, you hear back home when you have maids, right? And you're like, oh, I don't want to bring a male to my house because there's issue of molestation and all that, right? With the girls. Boys get molested too. And people forget that. Boys get molested. A whole lot of young boys were molested by their female housemates. A whole lot of them. And that's one discussion that people never talked about. And for some reason, a lot of these kids adjusted and, decided, oh, you're a boy, you're not even supposed to talk about it anyways. So, where you're a macho, so move on. And they moved on. But it was still there. And until some people begin to talk about those things, I was like, really? These things happen? They're like, yeah. Oh, Dr. Aluya, you had no idea? I'm shocked. But on both ways. And that's maybe when the trauma happened. And the kid grew up to a place where you can now express those things. And it's hard for him or her to come up and say something. It may be a cousin. It may be a relative. I had a female who was having issues with her husband. And guess what? Her mother's boyfriend molested her when she was 15 years old. And guess what? Even the husband didn't even know it. But because I sat with, we talk and all that, if I have issues and unresolved, I'll tell come back. I can give you 2 weeks to come back, a week. So you now have extra time to discuss some of all this. And she opened up and she cried. We took the steps on what next to do on how to address issues. So people go through, again, repeated traumas all through their lives. Talking about pastors. Pastors were human beings before they became pastors. They were regular people. And even as pastors, they go through trauma too. I know of a pastor who went into depression. I mean, it got to a point where if it wasn't for God's intervention, he most likely would have committed suicide. He was brought in here from another country to the parish. And guess what? The parish where he stood, because he stood up for what was right and righteous, and there was some misappropriation of funds, they wanted to get rid of him. And this is someone who moved, left his family back in this country and lived here. Now he can't go back. He's here stuck. That caused depression to a point where he will have to be kicked out of the house where he lived on, and the church would threaten him to report him to the IRS and whoever so that he can get him deported. So I knew what I went through, documenting, writing, and all that. And then guess what? That one drop that would have put everything over the bar was the day he was coming back despondent, depressed, and dejected. He was mugged. On top of that. So he went through it. I was the time I was seeing him every week. We became friends. But he went through and he healed up. So you can imagine. And I said, I understand. As a pastor, you still have to do your job. You have to pastor people and talk. Meanwhile, you're going through your own pain. They are loading on top of you, on top. So that these are issues that happen even to the most uttermost pristine and reverent individuals in our community. These things go through. And that's why, reaching back to your source of succor, your God, your spirituality is so important. And those are the things that will lead you on to getting a recognition of where you need to stand and how you stand. And of course, the Holy Spirit will lead you to that place. And when I talk about spirituality, I talk about the Holy Spirit. This Holy Spirit was poured out. It wasn't poured out for Christians alone. It was poured out for everybody. And that's the only way you can connect with one another. And that's the spirit that is in all of us, period. Nobody can take that away from you.
God bless you, Dr. Aluya. Is there a course that is given in medical schools called dispassionate concern, which in essence protects the medical student from the extraordinary views which is experienced?
You know what? In all sincerity, there's no one course. It's just over time, with your friends and your classmates and your comrades, you begin to desensitize yourself. I mean, if you've seen blood over and over again, you see blood next is nothing. You see wound over and over. The first time you see wound, you'll be shocked. I remember the first time I went to the L&D, labor and delivery, and a woman was giving birth, and I saw the blood like, ooh, oh my God, what is this? You understand? I'm like, are you sure? I'm like,
Is it the blood you really saw that bothered you, or
right?
the other part?
So, but repeated time, I was now doing the one taking deliveries. You understand? All by myself, and these C-sections and all that. So yes, over time, for you to be able to adjust into the process of which you've taken up for, because everybody's looking at you. People expect you to deliver. And in the process of delivery, unfortunately, even the senior doctors don't have the emotional intelligence as well to hold you aside, to guide you, to protect you, to preserve you, to lead you on. I'm at a hospital, at a teaching hospital. I have people who don't want to teach. And they're in the teaching hospital and they're professors. I'm like, geez. And then we have residents who are afraid to go meet certain doctors because they yell at them when they miss one or two things. I take a different approach. And I said, listen, this is the time for you to make mistakes. Because the ball stops with you eventually when you leave here. I said, and I make up for some of the things they missed. I'm like, well, team, right? They're like, yeah, Dr. Aluya, what team? What team, right? What team? And then sometimes I make them feel, okay, we discuss other things. We talk about NFTs, we talk about, and then I talk about the future of what the future would look like for them when they practice. I said, look, I'm old, I'm here, but this is what the future is looking like for you. And you have to take cognizance of that. So you begin to make them feel comfortable and relaxed and trust you. As they trust you, they make less mistakes. But we must begin to think like that. Emotional intelligence. So if there's anybody who don't know what that is, it's time to go research that. It's going to open and lighten your mind into a whole lot of things. And I've said this, and I say it this way. Each and every one of us ought to be leaders in our individual spaces. And we must take charge and leadership in that space. But before you become a leader in your space, you must have what I call the 3 E's of creating a leadership mindset. The first one is education. Education is basic. There's formal and informal education, where you learn from home, you learn from your uncle, everybody else. And then you have the formal one, where you're instructed in school and all that. That's it forms the fundamental upon which you run with anything else. Education, the first E. The second E is exposure. Being exposed to other people's culture, language, emotions, and everything else. And that's why they often say traveling is a form of what? Education.
Religion.
Go to India, you see all of those things. You look, until you come to the US, where you must have seen escalator in your life. And then the day they say climb that escalator, you're like, that is exposure, because you're exposed to something that's beyond you. You barely truly understood that again. And then the third E is the one that's most difficult. And that's what separates leaders from great leaders or exceptional leaders. The third E is enlightenment. Enlightenment is a personal self-sacrifice of a journey, and that journey is often spiritual. All the great leaders on earth went through all three. Jesus Christ, Muhammad, you name all of them. Look all their life. All great sages in our life, always. And it often takes a spiritual journey where you have to separate yourself from the lot. You separate yourself from everybody else so that you can sit and recommune with the spiritualness is in you and reconnect with that God that's in you. If you have all three, you become a leader. But if you perfect the last E, you become an exceptional leader.
Thank you so much. Herman from England says, enjoying the session, most informative with the various points and views made. And then he goes on to say, very similar to issues that Black community is facing in the UK. Great session tonight. Thanks, Dr. O, Dr. Aluya, contributors, and other participants. A follow-up session would be most welcome. Going back to Dr. Greg, he says, very complex issue with societal, political, racial, and spiritual implications. There is no one avenue that speaks to healing. It necessitates an awareness as a clinician, as a parent, as a friend. Mostly, we must listen, learn, and understand where that individual stands, whether it is an adult or a child. And a question from Susan Osefade. I so love the analogy of Eba and Egusi to illustrate the LGBT thing. God bless you. Then Dr. Greg comes in with another comment. We are a multinational, multidimensional, all-world society. Roles of all needs to learn new ways to communicate, touch each other. The traditional male and female roles are no longer if we are to educate and also support our children and friends. A comment from Marian, highly informative session. Thanks so much, Dr. Aluya. And then Dr. Busola says, great job, Dr. Aluya. Thank you, Dr. O. Tonyin Lawa, excellent, Dr. Aluya and Dr. O, well said. Richard Williams, another excellent presentation. Thank you, Dr. Aluya and others. Herman says, I will take note of the 3 E's. And then comes in, great presentation, Dr. Aluya, thank you. And then Vanji Okusanya says, great presentation, Dr. Aluya. You're getting a lot of plaudits from our contributors and participants. Thank you so much for what you have shared. It's now time for medical moment.
It's Dr. Aluya. You did it again. But guess what? We all echoing the same thing. You have to have a follow-up to this. We have to follow up. This is not concluded. You opened a can of worms. Thank you so much. God bless you. Thank you. Just before I go to medical Monday's moment, I want to put somebody on the spot. One of our counselors, amazing woman, despite COVID, she would come to your home if she needs to. Counselor Omirali, kindly unmute and just say hi, if that's all you. Unmute, you're still muted. There you go.
Hi, it was so wonderful, so informative. Everything was just beautiful. The 3 E's was excellent. Everything. What a wonderful presentation. Dr. Hallelujah. You did excellent, excellent, excellent. I truly enjoyed it.
Thank you. Thank you. Thank you for attending. So we look forward to seeing more of you and, maybe coming sometime to present and tell us about counseling. We want to open the eyes of our people to the fact that, as it has been said earlier, everybody seems to me lately have some kind of mental health issue. It could be small, it could be big. You may be able to handle it or manage it, or some people cannot manage it. But across the board, it seems like there is some mental health. We need each other more so now than ever before. So, thank you. So, Sister Monique.
Yes, hi.
So, my medical Mondays moment, I'm switching gears a little bit. I went to a wedding on Saturday, and I call her Mama, who was called to pray before we started, the full function, the ceremony. It's a Caucasian woman who has been married to a Nigerian man who happens to be a pastor also and a doctor for 50 years, 50 years. She took the mic and was speaking and had Nigerian accent. I'm not lying. She had an accent. And I said, I have to share today that, you know what, Dr. Aluya, when he was concluding his talk tonight, strongly encouraged that we all come together.
Yes.
He talked about the trauma that occurred when some of our forefathers were forcefully taken out of Africa to come be enslaved here, and the trauma that occurred to some of those that were left because it was family member that was taken away, be it a son, a daughter, wife, friend, sister, brother. I never thought about that. This is important. Sister George said there's so much to tackle here, to address. We have to take it off layer by layer. But by the grace of God, we will get there. We have work to do, but we will get it done because most of us on this forum are doers, and we're going to do it. So that's my Medical Mondays moment. I thank you all for coming. Dr. Aluya, go ahead, Honorable Gustav.
Thank you so much, Dr. O. Dr. Aluya, please, your concluding remarks.
Well, yes, trauma is true, is real. Repeated trauma over time accumulates, like the one drop in in that bucket that would lead to overflow. So the best thing is to stop every drop from coming in, or to empty the bucket. if it's getting close to being filled, or even if it's accumulating fluids, accumulating the effects of trauma. Depression is real. We shouldn't, sweep it under the carpet, especially in as we live here in the developed world, and even back home as well, in Africa, in Guyana, wherever you're coming from. There's a resilience that we had, that we thought we had as Black people, is slowly eroding away. Exposure, integration, and all that is eroding a whole lot of this. Just like I often say, that were not our ancestors, our children will not be us. They view things separately and differently. The baggages that we brought based on our religious connotations, whether imbibed, infused, or indoctrinated into us, they don't have the same. And if we don't begin to sit down, reassess those things, and dive deeply into this and reconcile them with them, and understand where they're coming from, as we understand where we are going as well, and understand the environment that the community that we live in is changing. Technology is changing a whole lot of things. The day will come, because our mothers and fathers can't operate the internet. There'll be technology that will come that you and I will not operate, but only them will be able to do that. We must understand that. The day will come where we can no longer drive because they'll take the keys out of our hands. As adults, as we approach those ages of our parents, we must begin to learn to preserve our minds and preserve our intellect as well. And one of the ways of doing that is exercising. Exercise, exercise, exercise. I always say that exercise keeps the bad doctors away. Don't ask me who the bad doctors are.
What about the good ones?
Exercise, because it increases the blood flow to the brain. The brain does not shrink, because like we said, if it shrinks, a whole lot of things happen. Even that trauma becomes over years, becomes to become prominent. The effect becomes prominent and it begins to show in a lot of ways. Depression is real. It cannot be cured, but it can be managed with a whole lot of things, with help, support, and structure. And people do get out of depressive state. And again, like I say, moving to the right or moving to the left, you shift them away and give them the support and intervene early enough so that we don't go there. Understand your children, understand where they live, where they eat, where they come from, the school they go, the choice of discipline, occupation that they want. Because you want to raise 3, 4, 5 doctors does not mean your child is not the best actor who will win Oscars tomorrow. If that's his gift and God has given it, let him understand and explore your role. Just like Joseph. Joseph could not stop Jesus Christ from what he became. His role was just to help be there and guide him. And that's what we are. So we must understand that, so that we together can begin to live a successful, productive life. And we'll sit down and enjoy our children in our old age. God bless you and stay blessed.
Thank you so much. Awesome presentation. We are so grateful to you, Dr. Aluya. Tonight, we delve into depression, suicide, and racial disparities with our speaker, Dr. Nelson Aluya. Thank you so much for contributing. Your questions and your comments, they make this program great. Till we come your way with another interesting episode, do remember to watch previous and past episodes on the YouTube channel, Medical Mondays with Dr. O, and do share the links. We love you all. Till we meet next time. Bye.
Bye-bye. Thank you.
Bye.
Thank you.
Bye.
Thank you all.
Hallelujah.
Thank you,
Thank you.
Dr. O.
You are too awesome. Thank you.